to a very, very relevant and interesting topic, especially today more than ever, when we looked at the pandemic and what did we face. We stopped traveling, we became virtual. We stopped looking at how we can see a doctor face to face. We stopped looking at how can we react. We responded. So what made that happen? The digital enabler. How did we look at it? The pivotal role of Outburst, integrated and interoperable health information systems in building resilience, was how we responded and did not react to the pandemic. I have a very interesting panel that will be up here with you. And we made sure that we didn't keep this straight after lunch for only one reason. It will be so interesting that you will have no time to think that you had lunch outside. So the digital enabler will make sure that it enables you to stay through and stay through to the last session. Professor Dennis Streveler, Professor of Medical Informatics, University of Hawaii. And every time I talk to him, I say, where is that sunset? And I'd like to see it. Because, you know, Hawaii is so famous for his Hawaiian shirts and also for the sunset. But on a serious note, Dr. Streveler is a PhD in computer science and in medical informatics who has devoted half a century. You actually beat me to it. I thought I was the historian. To improving the world's health systems by applying digitization and computerization to the process of healthcare, clinical, financial, and social. As a global expert in digital health, his work in India, China, in the last 5 years continues. And after having consulted in more than 70 countries around the globe, at home in Hawaii, Dennis is a professor of the medical informatics at the University of Hawaii. He has co-worked in Silicon Valley, including as the chief strategist for the WebMD Corporation and perhaps the most successful consumer eHealth information website. He's also worked with Kaiser Permanente, which I had the privilege to visit as a member of the ACHE, and what is a noted and a stellar name in the digital world. We will hand this over to him to moderate after we have all our panelists up over here. I am not going to introduce Dr. Ida again, our Economics Affairs Officer from UNESCAP, and she promotes the ICT for development at the UN Economic Social Commission for Asia and the Pacific. Welcome, Dr. Ida. Dr. Alvin Marcelo is online with us today. He's the Executive Director for the Asia eHealth Information Network. Alvin is the Executive Director and the Chief Medical Information Officer of the St. Luke's Medical Center in Manila, Philippines. He is a clinical professor of surgery, health informatics at the University of Philippines, Manila, and currently leads the Standards and Interoperability Lab, helping the government design profiles for viral hepatitis, surveillance, and other public health programs. As the director of the University of Philippines, Manila National Telehealth Center, and the Chief of Medical Informatics Unit, Dr. Marcelo established the Master of Science in Health Informatics program and conducted local and international research in the field of eHealth and health information systems development. Welcome, Dr. Marcelo, and we look forward to hearing from you remotely. I am going to introduce this legend again, the CEO of National Health Authority. He's currently sitting in the Ministry of Finance and hoping that that meeting will end. But as soon as he does join us, he will be on stage with us. Dr. Basant Garg needs no introduction. He's an IAS officer, a medical doctor by background, and is the current additional CEO of National Health Authority under the Department of Health and Family. And Dr. Garg was appointed as the private secretary to Sri Som Prakash, Union Minister of State, Commons and Industry and International Trade. Prior to this, he has served in the government of Punjab for over 12 years. I have the privilege of introducing another legend, Dr. Kevin A. Schulman. Dr. Schulman is our tag member at the Global Learning Collaborative and is a professor of medicine and associate chair of business development and strategy in the Department of Medicine, director of the Industry Partnerships and Education for the Clinical Excellence Research Center, CERC, at the Stanford University School of Medicine, and by courtesy, Professor of Operations, Information and Technology at the Stanford Graduate School of Business. So many hats. He is the director of Stanford's Master Degree Program and the Master of Science in Clinical Informatics Management. Dr. Schulman's research interests include the organization innovation in healthcare, healthcare policy, and health economics. With over 300 original articles and over 100 review articles, commentaries, and over 40 case studies, books, and chapters, Kevin Schulman has a broad impact on health policy. What a privilege to have you here. Yet another, somebody who has made a change in India is Kiran Anandampillai. Kiran is an advisor technology to the National Health Authority. He's a volunteer supporting NHA to create the digital public goods under India's two large digital initiatives, the Ayushman Bharat Digital Mission, ABDM, and the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, PMJAY. Kiran is a telecom engineer by training and was a founding member of On Mobile, where he helped it become a public company. He has volunteered with the Unique Identification Authority of India, the Aadhaar program, with the iSpirit Foundation on the health stack. He dedicates his time to driving impact in healthcare. He's the founder and the CEO of iDrishti, which delivers high-grade quality eye care from the district hospital to the village level. iDrishti currently manages 12 eye hospitals across Karnataka, India. Quite the legend in the Indian space. And thank you, Kiran, for being here. Dennis, it's all yours now to set the context and get the ball rolling.
Thank you. Is it on? Hello, hello. Great. Good afternoon, everyone, and it's great to see you all. I'm very happy you attended the session. I hope at the end of the session you'll feel the same way. Let me begin on a personal note. We just had some lunch, so let's relax just a moment. I want to tell you how old I am. Okay? I am as old within a few months as the state of independent India. Okay? So you can calculate for my Indian colleagues. So we've seen
I think he deserves a big round of applause. He traveled all the way from Hawaii to be here.
Thank you, thank you, thank you. I'm also as old as the first electronic computer, which was built at the University of Pennsylvania, Moore School in 1946, the ENIAC. It was the beginning of the computer age. It was the first digital computer. So in my lifetime, I'm very privileged to have two similar birthdays for your nation and for the computer industry. Now, when computers began, putting a little context in this, there were people who said, well, of course we'll use computers in health. And in fact, in 1966, the first electronic medical record system was attempted at Kaiser Permanente in Hayward, California, by a very ambitious doctor. His name was Dr. Maury Cullen. He just passed away, I think, last year. And he said, of course, Dennis, we'll use computers in health. This was 1966. Okay? We're now, well, I don't know how many years later this is. Who's good in math? A lot. And we're still struggling for the world to understand the importance of computers in health. Okay? And we're making some progress. The good news is, and I'm more optimistic than ever, that there's sort of an exponential curve that's happening, partly awoken by the devil of COVID, if you will, the opportunities given to us by COVID, also by the change in technology. We have always the day's buzzword. We had cloud computing a few years ago, which was everyone's darling. This year, it's artificial intelligence, as you probably know. If you haven't tried ChatGPT on your own, you really need to try it. It's eye-opening, okay? So we're about to enter another world. It's a bit of a buzzword, but nonetheless, it's going to have an enormous impact on the computing industry. So we have all of these changes that are going on in health. We have all of these changes that are going on in the computer industry. So where is it all taking us? Okay, now the next thing I'd like to point out to you is I kept a little poll during the sessions that have preceded this. And I gave up keeping track of the number of references to information systems. I gave up at 100. Okay? So, you know, I guess we're making some progress. We're usually the last session in the conference. Now we're the second last. This is some progress. Thank you, Dr. Reddy. And also after lunch, where everyone can be sleepy. I know I was yesterday. So I appreciate your forbearance. But we're making some progress in the world, is the attempt. And your country, those of you from India, should be particularly proud of the progress that's been made here. It has been really astounding. You know, I tracked the rise of China through its new period, and it, in many sectors, has exceeded any expectation in terms of growth and sophistication, but not in health. Right now, I would say that India is leading not only China, but most of the countries in Southeast Asia, even though they had a very long start on you. Why is it? Partly because of people like Kiran, who have had a vision for what should happen. We'll be joined by the additional CEO of the National Health Authority, hopefully soon, as he gets past his ministerial conference. It's people who have moved this along, not the least of which is your own Prime Minister, who, as you know, has been a champion for digitization across India. So for those of you who are Indian in the audience, I really want to congratulate you and point out the opportunity that now exists in your country that didn't exist many years ago. And the opportunity is for better health for all Indians as a result, that we can really look at outcomes and outputs, and we can actually measure the changes. You know, I visited a remote location in Uttar Pradesh before COVID. And while I was at this clinic across from the capital, a woman was dying in childbirth in the emergency room from hemorrhaging. And at the time, there really was no good ambulance system to transport that patient to across the river to the capital city, to Lucknow. And there really was no attempt to see if, in fact, that woman could be saved. This is sad, but true. And the reason I have retired 4 times and I'm still here is that until we deal with this problem in the world, where people don't die unnecessarily, I'll keep fighting. So we all need to keep fighting. And one of the tools we have is good information. And we hear it batted around many, many times about the need for robust information systems and integrated information systems and interoperable information systems. You can use whatever adjective you like. But what we want at the end of the day is these systems to be able to cooperate in providing better health for everyone. There are 3 main modules of a health information system that we're going to look at. Actually, the domain is much larger, but for our purposes, we're going to define it as 3. The provider systems, so that those doctors and nurses and other health professionals have some continuity of care across levels of care, across specialties, across states, across crises, so that we can better treat not only communicable diseases, but the emerging non-communicable diseases as well. So the challenge there is to make sure that these systems become available to everyone. So provider systems includes the public health systems, it includes the laboratory systems. We could go on and on. The taxonomy is very large. But for you, just think of it as all of those systems that have to do with providing care to patients. Okay? Second is the health finance side, which you heard ad nauseum, thanks Jack, in the previous session, right? We could concentrate, and in the NHA, we could concentrate on only how do we improve health finance. But of course, health finance has its other end. Health finance provides money, providers spend money, right? And so how do we keep this balance that we've heard about, not only between the public and private sector, but between providers themselves, is to create a balance there so that neither side dominates the other, because they're both important and irreplaceable stakeholders. And so if one completely dominates the other, you're going to have a very unhappy health system. It might be working, but it'll be full of passive aggressiveness. So the health finance system has to be itself very complicated and very strong. And probably India's health finance system, here's my prediction, will become the world's largest information system, period, in any sector. Okay, that's how huge it is. Not only because of your large population, which obviously is a factor in any time we talk about India, or China for that matter, but also because of the complexities. At the moment, you have 20,000 packages? Not that large, 15,000. How many? 1949. Okay, some countries have 50, right? So being able to look at the utilization of each package and being able to use it and analyze the outcomes that are connected to each package, it becomes a gargantuan task that only computers can deal with. So the computers are absolutely important in the health finance system. Finally, in the one that maybe all of us forget about, is the resource management systems. So we've talked in a couple of sessions about human resources. I mentioned, I think yesterday, in a question that I posed from the floor as to how do we deal with shortages in specialties and in pulmonologists and cardiologists, et cetera, that were needed during the pandemic, for example. But to rationalize human resources across the country so that no one area is left out with access to needed care. And of course, supplies. We all know about the oxygen issue in India that happened during COVID. I was home in Hawaii. We didn't have that problem, thanks God. We had other problems. But we kept thinking, Why is there a shortage of oxygen? What happened with the planning? What happened to the distribution of the tanks? How could we have made that better? Could we have at least ameliorated that crisis? And so we've got to deal with goods. We also have to deal with services. So I'm very happy to see one of the early initiatives of NHA was the registration QR code method of providing patient a entree to a clinical appointment. This is a very straightforward application, but it really helps to rationalize services. I'm sure if I'm sick, I don't want to really stand in line for registration for hours on end. So those are the three main components, but they're in a milieu. They're connected together. Like Office Suite, I'm sure most of us use Microsoft Office Suite in one way or other. PowerPoint is connected to Outlook, and Outlook is connected to Word, and Word is connected to OneNote, and whatever is in the suite. So think of it this way. When Microsoft first began those programs, they were independent. Word had nothing to do with Excel and so and so. But finally, people said, no, we need harmonization. We need these things to work together. They're more powerful working together. So harmonization and integration, interoperability, any of those adjectives you like to use are so evidently needed in a health information system for a nation. Now, we're in different places in health information systems. We've got some countries, I'll use Australia as an example, that's been chugging away for at least 25 years. At least 25 years, and they've done some great things. But you know, now India has an opportunity. The greenfield effect in India gives it the opportunity to really move ahead fast. Because brownfields have a lot of legacy constructions that have to be redone. So in India, yes, you have some brownfields, but you have in health mostly greenfields when it comes to health information systems. So let's use that opportunity now and grasp it. Now, one more thing before we move on to the panel. We talk about information. What the hell is information? What do we pay to collect information? Well, I want to leave you with this tiny, tiny tutorial on what good health information is. Because we want to only pay for information we can use that's good, right? Good. Air quotes. What do we mean by good health information? Let me give you 5 criteria very quickly. It has to be relevant. You know, I filled out a form for my missing baggage in Air India the other night. You probably noticed I'm wearing more or less the same outfit every day. And the form was, you know, what's my home address and what flight was I on? They knew all of this from the tag, right, and from my reservation. But they collected it anyway. We do this every time in the systems that collect vertical information. We collect the same information over and over and over again. So is it relevant? Well, yes, maybe, but it's also being duplicative. So can we avoid that redundancy? So we want relevance in our health information. We want timeliness in our health information. Information, some people in some of the sessions talked about real-time data, and I don't know how real-time is real-time. We'll leave that for another discussion. But timeliness is important. I was in the Ukraine, thanks God, before the war, and I asked the minister to show me their report on HIV in Ukraine. And he said, Dennis, we have this great report. He pulled it out of his shelf, which most reports end up on, right? And it turned out to be a 4-year-old report. And I said, with all due respect, Your Excellency, a 4-year-old report on the incidence and prevalence of HIV disease is not going to give me much information about what's today. And with a fast-moving pandemic, we should probably learn that lesson even more. So we need relevance, we need timeliness. Don't pay for it if it's not timely. It's not worth collecting, right? We need coverage. Well, unless it's a research study where you're sampling data, we need total coverage. So it doesn't really help to do a pilot in Kerala and then find that we're trying to extrapolate that data for all of India. It's not going to work, obviously. So We need coverage. We need, and in India, this is a big problem because of your size. We need completeness. The single biggest attribute of health information is not specified. The thing I see most in health data, not specified or otherwise specified, or you know how the ICD book is, for example. So we need data that's as complete as we can get. Okay, and finally, we need accuracy. We talked about accountability, and we talked about transparency in data introduction in previous sessions, so I won't go through this again. But data that's hogwash, which is the construct of the chief minister and no one else, is not going to help us. And by the way, it's certainly not, I'm not indicting India. This is every country in the world somewhere has this problem of hogwash health data. Please, let's not pay for or promote hogwash health data. We want accurate health data. If we can't get it, we have to find out why we can't get it and how much we're willing to pay for it to be accurate. Okay? Because I'll give you an example. I was in Albania, and we had cheat sheet forms for the diagnoses for the doctors. So they could just check off the diagnosis. Okay, on the top of that form, for some reason or other, probably because of its ICD code, malaria was the first thing on the list. It turned out that malaria was the most prevalent diagnosis in Albania, a non-tropical country, right? So I think they had no malaria cases, but according to the statistics, they were overwhelmed with malaria, right? So we have to be careful of this. So before my voice goes completely, I'm going to turn it to the panel. And we have absolute experts in a number of fields across the globe being represented on this panel. Thank you. I should mention I'm also suffering from some long COVID things. Anyway, we won't bother with that. So let's begin. We're going to divide the session into two pieces. One, we're going to talk about routine health information systems. The bread and butter systems with the applications I just talked about, working together in some kind of collaborative way. Provider systems, health finance. Excuse me, health finance systems, and resource management systems. And the second section of the talk this afternoon will have to do with resilience. Too much adrenaline, I think. So we'll try to break it into two pieces. So I'm going to start the conversation about routine health information systems and why we're so far apart from the rest of the world in terms of using information systems in health. We're probably 50 years behind. The finance industry, the airline industry, even education, we're falling behind. So what is it about health information systems, Kiran, your experience at the NHA and elsewhere, what has kept us back? Let's start with that.
Well, I'm not sure if I would be the absolute expert to know what has kept us back, Dennis. But I do agree with you that if you really look at other industries, and especially in India, adoption of health systems on the provider side has definitely been far lower than I think what it should be. And my sense is that this change in behavior that's required. So, you know, the most common thing I hear, at least, I've started working with some public health systems, and when I meet the doctors and the others, have you seen a form that they usually ask a doctor to fill out? Yeah. So it usually starts right at the top.
Does it look like Air India's lost baggage form?
Yeah, absolutely. And most doctors are telling me, hey, I'm seeing 100 patients or 80 patients. How do you really expect me to sit and fill it out, right? So I do think that, you know, they're not wrong. You know, they are, unless we can actually solve for their problems, I think it's not going to adopt, right? So the two ways you can go about it. One, you can say, hey, you can see only 30 patients a day and I'll give you 10 minutes per form to fill this out, which is unlikely to happen. right? Or you'll have to say, okay, maybe I don't need all of this information. I think the thing that I find very interesting is that the design side, like when we actually decide what to put in, usually that's a very top-down process still in many of those decision making. And I think it could really help if we probably started looking at what happens. The second thing is, I think, how much value do they find for themselves? Why are they feeling this, right? I think we need to also identify strong opportunities where they're getting something back from the data that they're putting in. And I think that's what's the second piece that's driving adoption. And I think in many of the scenarios in how in their day-to-day practice of the practitioners using these tools, I think they probably don't see enough coming back. The third is, are there incentives? And in many of the countries where there is a lot of, in fact, probably too much data goes in healthcare, it's also been driven by payers and payers demanding that happens, which in an out-of-pocket market like India, they're mostly answering the customer.
Please, Dr. Basant. Nice to meet you.
So I do think, but that said, I am an optimist. I mean, I can't visualize when I think 10 years from now that people will still be just using a paper and a pad and not using any digital tools. I think the space at which solutions and digital tools are evolving, and then the value for why they should be doing it is evolving, is changing at a very rapid pace. And so I'm a big optimist that even in low resource settings or settings where this is not the case, that we will see that shift happening. I think the National Health Authority has, with this whole ABDM mission, has actually got quite a few initiatives to try to make that change or shift kind of happen.
I think, too, one thing we can do is improve the user accessibility, usability of these systems. Let me give you two very brief examples that I've seen in other countries use. We always collect dates, yes? Date of service, date of discharge, date of admission, whatever. Date, 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 date. And they put the same date, or they probably put that wrong anyway. Let me give you a hint. Today's date is T. T. Put a T in the form. That's all. And the computer knows what today's date is. Why are we asking them to put it in each time? Another clinical example. With 99% accuracy in most specialties, the new diagnosis for today is the same diagnosis as you had yesterday. So why am I collecting the diagnosis again? How about something same as previous? And be done with it, right? I mean, I can give you a whole list of those kinds of shortcuts that we could take to make the physician's life more sensible. So Dr. Basant, from the additional CEO from NHA, has been, it's our privilege for him to join us. And you missed my rampage, but let me turn to you. From your experience at NHA, or let me put it straightforwardly. I don't know if we have any newspapers here, so we can speak honestly. What would you do? What would have NHA done differently today if you were a country that was just beginning, let's say with a UHC, National Health Insurance System, or some major initiative like your Prime Minister challenged you with? We're now 3 years down the road with, I guess, NHA development altogether, something, four. So what would NHA or what would the government have done differently? What would be your advice to those countries in the audience who are following India and still have an opportunity to learn from what's happened?
Yeah, thank you. I'm sorry, everybody, I was a bit late. I was held up in a meeting. So coming to your question, let me say that India embarked on its journey on social health insurance in 2018 with the PMJ scheme, the Ayushman Bharat social health insurance scheme. Unluckily, we chose a very bad database, and we went, we adopted a database which was not having any unique identifier, And that is why our scheme took 3 years to take off. And it is only in this fourth and fifth year that the scheme has seen the right kind of uptake with the number of hospitalizations and the utilization of the scheme actually meeting some expectations. So coming to the question that what would we have done differently, I think if we had to start again, we would have started by using a better database, which is uniquely identified by the national ID, Aadhaar. Then the second important thing which we would have done, given our experience with the digital mission, we would not have just thought about the social health insurance scheme from a provider side. We would have thought of it from being an ecosystem enabler side. And probably that would have helped not just the scheme, it would have helped the whole health ecosystem. So those are the two major changes.
Thank you, Dr. Basant. No, I think it makes a lot of sense, and I hope people in the audience have listened very carefully to those, because I think they're very, very important. Let's turn our attention to the Philippines. Do we have Dr. Marcelo on the line? Alvin, are you there?
I'm here, Dennis. I hope you can hear me.
I can hear you. I can't see you at the moment, but oh, there you are. Alvin is one of my former students, so I am very proud to always talk with Alvin. We've been friends for so many years. Alvin, Philippines got started early. I mean, way before India, in fact, with PhilHealth. I know you were at PhilHealth for a time. Alvin's in a very interesting situation because as a physician, he's a practicing surgeon. As a professor, he teaches medical informatics. As an advisor to the government, he was the CIO of PhilHealth, which is the equivalent of NHA. And he's also now in the private sector at St. Luke's Hospital, one of the major hospital chains in Manila. Call it Apollo in Manila, if you like. Anyway, Alvin, what have we learned? And what do you take away from this long experience that we can serve to the rest of the world from the Philippine experience about designing and implementing these systems and getting adoption?
First of all, thank you, Dr. Dennis and Dr. Reddy, for the invitation. It's an honor to address the audience. I'd like to take off from Dr. Basant's comment about the importance of identity. That has been, the weakest point in the PhilHealth system would be the ability to understand what is the scope of the clientele, of the public, of the universality, of the citizenship of everyone in the Philippines and their inclusion into the system. The law was easily passed in 1995 that everyone will be covered by social health insurance. But without the identification system, there was a big question mark about how big is this universe of Filipinos that we need to insure. So I really concur with Dr. Basant's understanding of the challenges of identity and the power of being able to support the whole population, because they are, in fact, within the identity system, the identity management system of the Philippine Health Insurance Corporation. I would say we started earlier than India, but I'm looking at the progress of India right now with ABDM, and I'm really very interested in how they're going to solve this challenge of national health insurance, Dr. Dennis. I hope that I can learn something today, and that I hope we can also bring in the lessons of India to the rest of the Asia eHealth Information Network. There are other countries that are looking up to the Indian solution, so to speak, and I'm happy to share our pain points, some of our lessons about identity and why it's so important. And to me, I think the other thing that I'd like to share with the group is the importance of standards. Without the standards, I think we are just going in different directions and in different places, and we're all talking about the same thing, but applying different meanings to the same terms. So identity and standards, I think, are the two things I would share with the audience right now, together with Dr. Basant. And anything that we can bring back to the Asia eHealth Information Network, I hope that we can relay this lesson back to the other countries. Thank you, Dr. Dennis.
Dr. Marcelo, thank you. Maybe while we have you on the line there, can you tell our audience how they can learn about the Asian eHealth network, information
Thank
network.
you. Thank you, Dr. Danny. So the Asia eHealth Information Network started with an informal discussion group of people who are passionate and advocates of interoperability in their countries, understanding that they didn't have interoperability within their countries. That's way back in 2010. We got a small fund from WHO and NORAD to strengthen this network. And from a group of 7 people from 6 countries, we're now up to 1,800. All still looking for the solution. And so we look up to the Indian progress right now that they might have the solution to this monumental problem of identity and standardization, which are the foundations of interoperability. And we have weekly meetings. The network is really intent on learning from each other. And we know that India is way ahead when it comes to technology. And we hope that we could, like share experiences also with the other countries that are still just starting out with their social health insurance capabilities. Thank you.
Thank you. India is ahead in some areas, but the Philippines has the longest history. So the PhilHealth network, which was, I think, the first national network for health information for health insurance in the Asian market. I may be wrong, but I think it was the first. And so we can also learn from their experience. They had a very integrated system, or they tried to, from the very south of the country to the farthest north. It was all connected. And that was at a time when telecommunications wasn't so cheap and so reliable and whatever. But it worked, and it worked quite well. And 2010, Dr. Marcelo?
Yeah. Yes.
So, that's a long history already. In the world of computers, that's several generations. So we have a lot to learn from each other. And the AEHIN is one vehicle that I would really suggest. If you want to get on their mailing list, please find out how to do it. I get about 3 emails a day, I think it is, from Manila. And almost every day there's at least one that is very, very useful. So I recommend it. Thank you so much, Dr. Marcelo, and thank you for joining us today. Finally, a very poorly known commission within the UN, which is represented by our friend Ida, who certainly has the record for serving on as many panels during this conference as anyone. But we invited her to be on this panel because she represents a very important element of information systems, and that is the social aspect. And her commission is called, oh my gosh, Economic and Social Issues. And she has been working in information systems, particularly with something they call e-resilience, which is obviously in the second half of this parade this afternoon we're going to try to focus on. But please, maybe you can tell us your interest in computers, and from your vantage point, what do you see has been working and not working?
Thank you very much, moderator. And I'm very humbled and very happy to be with all of you and to learn and share the wisdom. And I thank you for your question on how did I work with computers, but I think it's from the beginning, it's all about information systems. My basic education is chemistry, so I used to look at information systems from the chemical point of view, and I also looked at from the biological point of view as biochemist. I have PhD in biochemistry. So I used ICTs and algorithms to predict the homology of amino acids and nuclei sequences in different organelles like mitochondria, nuclei in plants, in animals, and and very simple cells. So that was my background, and since then, mathematics and informations was always accompanying my work. And Economic and Social Commission for Asia and the Pacific, if you look at sustainable development and the pyramid, it's a high-level body for decision making in the region. It's like international parliament. Maybe that's why you don't know our work. But our job is to keep ministers informed on like frontier policy making. So we have to read, and I'm using my background of scientist. We have to read, grasp, and present in a visually appealing way information, which is very complex to the most active minds, from whom a lot of decisions, the whole world depend on the decisions. And the recent work, as we mentioned yesterday and today, we're talking about e-resilience. So we look at e-resilience of infrastructure, which is supporting societal resilience. So two aspects. So infrastructure and its networks provide connectivity, and connectivity provide inclusivity. So that's a simple way. And here we look at speed of the digitalization or digital transformation. So when we talk of digital transformation, it's not about the data log only. Digital transformation is a whole society fabric of change. So it's a whole value system. It's not only the operational systems and the digital databases, but we look how we deal with that. And all of us now challenged, right, with OpenAI, smart, intelligent, no. opportunities, and also the joy of thinking as a human, right? And trying to outsmart all these computers. So back to the speed, digital transformation is actually creating a big bang of opportunities. With COVID especially, if you look at socioeconomic profiles of countries, COVID affected countries, and then you could see the difference and the yarning up between low-income countries and advanced countries. And it's a K-shape, right? So those countries that are advanced, they are rising up. So corporate and big firms, high techs, they're becoming richer, and small and medium enterprises and industries that are like cycling their economy, they are going to the bottom, and low-income countries also suffer. So with this K-shape, the speed of that development also different. So once you have this structure in your mind, it's easy to orient. You can coach your students, your different systems. So with digital transformation as foundation, you are laying the basis of digitalization, creating digital skills. With digital adoption, you create better networks and you create a digital economy. And with digital acceleration, you try to engage the marginal groups, make better inclusivity. So your infrastructure is actually managed by people, by governments, by business, and it's creating an ecosystem. So once you have this matrix in mind, you can find out where you are as a country, as a system, and how would you like to interact with through digital transformation with other systems. Are you in the market? Are you in creating a new ecosystem? So with this, we have a landscape of Asia-Pacific countries. Our colleagues like Frontier of Policy Making and Digital Transformation, we invited them from Korea. They helped us. There is not much data, but we managed to do the scoring of countries where they are on digital transformation index. But then, no matter how much we talk about acceleration transformation, you need to deal with another aspect, which is e-resilience. It's ability of your system to withstand external shocks. So imagine you are very well developed, you have a network, your digital transformation index is high, but then your hazard and exposure is also high. So what will happen with your system? So in that space, early warning systems and information around that will matter. And here, yesterday we highlighted it, I want to highlight again, the 6 pillars of resilience. We created methodology where we can also help countries to create collaborative frameworks, where the first pillar is infrastructure, Second pillar is policy. So what policies countries are operating. Then we deal with data and the management of data. The fourth pillar is all about new systems and applications. And you have to, if you're modeling this, you have to look at the hazard and exposure. So if it is earthquake, if it is avalanches, if it is war or pandemic. So you can create that model and compare and see where are you network ready to go to digital transformation acceleration, or you need to go back to the foundation space and use your, I like health access is also trying to do the health informatics now, right? So how do you operate with that? So yes, thank you for your interest on e-resilience. We created the open data in Power BI format. It's accessible. We have created pentagram shape of e-resilience framework. So it's a complex structure, but in a very simple picture. You can see where you need to collaborate and outsource your data or information or resources at the country level. But you can use this framework as a change management framework in any other aspect. Thank you.
That's very useful. And I hope you will look at their website. You want to give the website address?
United Nations escap.org. And then we have e-resilience, e/resilience area of work. And you will find a special chapter, a project on e-resilience. And then you can look at it's connected to the map, it's connected to the internet speed map. You have pillars, and for a few countries, 6 countries, we compared the data of e-resilience in 2020 to 2022. So you could see the progress, and you can look at the policy framework. So this or that aspect to see what is that change, the delta change, and how to manage and manipulate it to improve towards sustainability.
Thank you, Dr. Ida. Finally, we have a panelist, Dr. Kevin, who's going to be given an impossible question to answer, and that is to sort of sum up the experience of the advanced economies, particularly the USA, and what can we learn from the USA's efforts in creating these 3 systems, provider systems, health finance systems, resource management systems. What can the world learn? What should they learn about the good and bad aspects of our long experience in those systems?
Great. Well, thanks Dennis, for giving me a really easy softball question right after lunch. So I want to talk about, Dennis said, the United States, we've been looking at electronic health record systems since the 1960s. I have a slide of the computer language called MUMPS that was created in Massachusetts. Yeah, about the same time. Yeah. And adoption was relatively slow and sporadic. In the wake of the financial crisis in 2009, the federal government in the United States was desperate to make investments to employ people. And the idea of electronic health records had been around for a while. There was bipartisan interest in electronic health records. Hillary Clinton and Newt Gingrich were both enthusiasts about health records. And so we actually invested a significant amount of money in getting physicians and hospitals to adopt electronic health records. And for most, the strategy was, well, if we adopt these things, the government's going to pay us money. And that was at some level, at some very crude level, that was the strategy. Our National Academy of Medicine went to look at the economic impact of the adoption of electronic health records, and the first idea that they had when we did this was that we would need less files in our paper files in our medical records room. And so the concept of electronic health records was to replace paper records with digital records, whatever digital was at the time. But we didn't stop and look back on a couple of really critical issues. So the first is, kind of why would we want to, what could electronic health records do? Or what could digital technology do? So I'm kind of different on the panel here because my background's in economics and health services research. It's not technology, even though I run a master's program in technology. And then the perspective I take is technology is part of a business process. And so we want to automate business processes to improve productivity and to improve accountability. And so we didn't ask that question at the beginning. In fact, most physicians would never heard of a business process, which in technology world is a use case, right? So why are you collecting this information? It's come up a bunch of times. What are we going to do with that information? Where would it go? So the economic model, when the United States adopted technology, really had nothing to do with productivity because we didn't even start a discussion of what our business processes were and how technology could augment those business processes. The second huge problem with the United States adoption of technology was data architecture. The world's most boring topic, but the world's most important one. And so if you say what the use case is, why would you want an electronic health record? I want an electronic health record because when I go to Dr. 2, I want them to know what Dr. 1 thought. Or if I took the medication last year, I'd want the doctor to know about that. Okay, that's the primary use case. And so how would you make sure that when you go to the physician, you have your record with you? It seems like a pretty solvable problem. The way we decided to solve that problem was to have a record oriented around every doctor in the country or every hospital in the country. And so then the only thing we had to do was to figure out how to get the records of every single doctor in the country to talk to every other doctor in the country. And if I could figure out which doctors you were going to go to, and if I could build an interface between each doctor's record system, then actually I could get your information about your visit last year to your visit this year. And I would suggest that it's like the worst architectural solution to how to solve that problem that anyone could ever come up with. And so this whole idea of interoperability was how did you make one thing talk to another that we're never going to talk to each other, and there was no business use case for my record to talk to your record. And so I don't want to make it interoperable, right? If it's not interoperable, you got to come back to me to get your record. That's really a good business model. So the architecture that we adopted solved the problem of the medical record room, but didn't solve the problem we're trying to solve. So now we can fast forward a little bit to how, what are we trying to do today? So one is I still have that use case. I still, when I go to the doctor next year, what happened last year? Okay. How do and then the next use case is we're all excited about, I come from Stanford, so except for COVID, the only other thing we talk about at Stanford is machine learning. And so how do you build a machine learning database? You get lots and lots of observations over a long period of time. The more valid the observations, the better the algorithm. If you go to an AI conference in healthcare, every single presentation goes like this. I spent 5 years building a data set, and it took about a week to run the algorithm. Because we don't build massive data sets of longitudinal data of people over time. So the biggest failure of health information technology during COVID in the United States was we actually got paper records that we got vaccinated. A paper record. So in the United States, we gave out hundreds of millions of doses of vaccine, and all our information about vaccine efficacy came from Israel, because they actually tracked what happened to people after they got the vaccine, and we had paper records. We couldn't do anything with it. And so as you're thinking about the modern use case, the US examples are really great, unfortunately, about what not to do. And so our job right now is not, it's not to build electronic health record systems for hospitals. Because if a hospital thought electronic health record systems would improve their productivity, they would have bought it. Like you don't have to pay, you didn't have to pay the banks to adopt electronic health, banking systems. They thought it was going to improve their productivity. So we've still had trouble defining productivity use cases on the doctor and hospital side. We have no problem defining a productivity use case on the patient side. And so that record, how do I get my record from here to there? What medicine did I take? Why am I taking that? I've been talking to people, so one of the huge failures of healthcare is the absence of TikTok videos. Every single time you go to the doctor, you should get a TikTok video about what medicines I wrote a prescription for and how to take it. It would take 2 seconds for us to do that. It's such a failure of imagination that we're not thinking about how to use technology to solve the primary use case, which is get the patients to improve their blood pressure, improve their diabetes, and take their medicines, and know about their medicines and know when they have a side effect. Okay, if we could do all that, we would dramatically improve the productivity of the healthcare system, and so the architecture should follow from those use cases. And we could build more complicated use cases on top of that, but to me, that's really exciting. So when we talk about legacy systems in the US, and you would think, oh, we started so early, we must have an advantage, I would argue the opposite. We started so early that we're locked into 1968 ideas of computing. But we should start with a 2023 idea of computing, of ubiquity and cloud. You know, again, we did, our high-tech act was in 2010 before anyone that wasn't an expert knew anything about a cloud. Like what was, there were plenty of clouds in the sky, but we didn't think about data. So imagine spending what we spent on electronic health record systems and not having it be cloud-based, okay? And not having access to, each one of us to have access to our information when we want it. And so these were all the things that we did, but understand part of it was not a strategy for the healthcare system. And when we adopted electronic health records, it was a financial crisis strategy that got us started. And now we're trying to go back and resolve these equations. So we're trying to ask the question, what is productivity? How do we use technology to find productivity? How do we use scale so that the interface, you're all playing with your cell phones, which is fine, but you're all playing with your cell phones because the interface is so easy and so useful. All right? Why is the interface not so easy and so useful for the 1 million doctors in this country? Because we architected around each provider. At Stanford, we have about 1,600 doctors, right? We build an interface for 1,600 doctors. Apple's building an interface for 2 billion people. Which one's better? All right, so we need to think about scale and using technology in the way that's most appropriate today. And so I would say, I think you're in a much better position to define these use cases and to define the productivity model, and that'll make it much easier to solve technology.
Thanks, Dr. Kevin. Well, I can't disagree with anything you've said. In fact, I'm hoping that the world kind of looks at the Indian model, for example. And by the way, our colleagues in Southeast Asia who are here as well. I mean, I think there are opportunities that we can see in the lower and middle income countries and the quickly advancing countries that have opportunities that we couldn't have imagined in the city in the 60s and 70s and 80s in the US. So I think the models that people will look at in the next 10 years are going to be created here in Asia. And you could all be part of it. So time is running. So I want to, if Dr. Kevin, if you thought that question was a hardball or a softball, wait till the next ones. Because I want to do a really quick round about resilience itself. Right? This is the theme of the conference. And even though Dr. Ida was kind enough to talk about resilience in her answer, I do want to spend a few moments focusing specifically on resilience. And I'm not sure who my first victim is. Let me go to Manila. Dr. Alvin, are you there?
I'm here, Dr. Dennis.
Please, what has happened in Manila? What have we learned from, I know that, Alvin, you didn't hear the earlier sessions. So they were talking largely about the fact that humans have short-term memory, and all the learnings from COVID are going to go away as soon as we took off our masks, and everything is fine, and we're back to never another pandemic is going to happen. And our politicians are thinking that, and our people are thinking that, and I don't know if I see any masks in the entire room, including myself, right? We're very happy to shed all that. It's past history now. Well, it's not past history, as any bioinformatician would tell you. What has lingered in the Philippines, and what do you think the longer-term implication will be for people's appetite to support and design more resilient systems?
Well, in the Philippines, Dr. Dennis, what we learned during the pandemic is that we weren't organized interagency-wise to manage a disaster like that, you know. So I would summarize the lessons for resiliency to be governance, to have a governance capability and a structure that we can quickly gather together, interagency, just within government, and be able to tap into the capabilities of the private sector very quickly. It took about 3 to 4 months to get that up. I don't think we should spend another 3, 4 months in the next pandemic, because we already know that governance is key to getting all the resources in a synchronized form and activate all of the solutions that are in separate departmental agencies in government. So governance, I think we should evaluate the past 2 years and come up with a blueprint for addressing disasters like that. We should not be scrounging around in the whiteboards all over again and drawing things that we already had drawn before in the COVID-19 pandemic. I think the blueprints and the artifacts that were generated in the past 2 years should be easily available, accessible, and shared with everyone. Even if the pandemic signals are already down, I think we should look at those blueprints and always make sure that we have access to them in case an emergency arises. Third, the people. We need to make sure that the people are knowledgeable about the governance structures and the blueprints during disasters. And finally, again, I go back to the standards. If we know what standards to use in times of pandemic, and the reason we know what the standards are for a pandemic is because we're using them for routine. So we should start using routinely the standards so that when the pandemic hits us again, we're not, looking for what standards are we going to use within the country and across the borders regionally. So GAPS, governance, architecture, or blueprint, people, and standards. Thank you, Dr. Dennis.
Thank you, Dr. Alvin. I'll turn to Dr. Basant. Are the NHA systems today being designed in a more resilient way as a result of the COVID experience in India?
Right. So, my take on this is the E in the E resilience comes first. So, you are right. Resilience is a very important part of how we design our systems. With the learnings of the digital mission, we are able to do that better now. And COVID, the Indian application that was designed and India's response to COVID as such has given us great insights. I agree with the speakers here that to the extent that resilience is important, but it's not just the e-resilience that matters. I think, as was earlier talked about, the governance structures in India during COVID, they changed, they transformed as the need was at that time. We had the whole of government approach. Not only within government, we were able to find partners outside government. A lot of private people, a lot of private entities and partners, they helped shape India's response to COVID. We learned that digital systems are very important when designing systems for populations of this scale and ensuring that services are delivered transparently and with accountability. And next time faced with such a problem like a pandemic or a disaster, I think these learnings will come in handy for us. And of course, a country of India's size would always need to depend on digital ways of delivering services. Otherwise, it is very tough to reach out to such a large population. But we also need to keep in mind that a large population of the country is not connected to the digital system. They are not habituated, or they don't have a behavioral change in adopting these digital systems. And those are aspects which we need to maybe work on before the next pandemic or before a next disaster hits us. So, I mean, those are the points.
Thank you so much. Kiran, what would you add? When you look around India, outside NHA and in the general milieu of business systems and clinical systems as well, do you see that this impact is going to last, that the memory of COVID is going to persist, and that we will, in fact, follow through on what a year ago, when we were all wearing masks, we thought our life had changed forever? But is it persistent? Does India have a long memory or no?
Well, I think, so let's think about COVID, David and Dennis, and it was impossible for the government to respond if it did not know how many positive cases were happening, where they were happening from, and if we couldn't get that information to the appropriate administrators, right? But the question is, how did we do it? How did we get that data? So, at the point when the pandemic happened, there wasn't really a digital infrastructure readily available which could give this information. And so, one of the things that happened in India, and I think most of the parts of the world, was that you had to put something in place quickly so that you could capture every test, capture some information from every test, and have that information flow. Now, the pandemic was a point when I think everybody, the world rallied together so you could get that change to happen. Because the change meant, of course, somebody built a system, but the most important thing meant that every provider who has some software system now actually had to use a second system to update their COVID information. So if you had gone to a lab in India, you would find that there was slight delay. They would actually have the test, they may have the result, but they had to also punch it into a second system from which the data flow that was actually happening to the government and all of the things that we published were happening. Right? Now, this is okay because we're talking about one test or one type of test for one disease. But this is not a great architecture or a system. If you say, okay, I want this for health data, can I actually use this for other things, right? So I think that's one part I want to say. And the second thing is, I think you can never get away from the diversity of solutions that various providers need. I think, what a small clinic needs to a hospital needs. So the world is always going to need innovation at the front line in terms of different kinds of systems. But so what I think most countries need, and I think even what India needs, is really what I think of as a digital pipe in the back with a way by which any of these systems can actually connect. And that's really what we are trying to do with the Ayushman Bharat Digital Mission. And the Ayushman Bharat Digital Mission was born in the pandemic. So in some sense, you can say it was kind of a response to the fact that there was a recognition that we needed to build a more interesting infrastructure, right? Going to what Kevin was saying as an architecture, right? So what we're trying to do with the digital mission is to try to say, hey, let's have a way by which we can identify every patient digitally in a unique way. And let's make sure that we give them their records. So we are hoping that they can carry their records around as they go through the system, go through different providers, while at the same time extract certain amount of information out that's useful for public health purposes, right? So that's at a very simple construct, while allowing, systems in the front to continue to be able to be innovative to service the needs of their particular kind of provider. So I think I do hope, and I'm very optimistic, but the digital mission is not really something that will give us short-term results. Like COVID, we needed the results day after tomorrow. The digital mission isn't really that kind of a thing, and we still need to find, and that's one of the big things that I think Dr. Basant and others are working on, is how can we get, India is also 200,000 providers, and how do you convince all of these people not only to adopt digital systems, but to make sure they plug their digital system into the needs of the digital mission, right? So that's really the journey, and I think we're making progress. I'm, of course, an optimist, so I'm very hopeful about how this will pan out.
We need as many optimists in the world as we can get, Kiran, and we appreciate your optimism always. So thank you about that. And this notion of the unique patient identifier keeps coming up. I think it's the second or third time it's been mentioned in this session. I hope everyone's listening to that, because so many countries go through this same process. They say, oh, we don't need a unique identifier. We'll use the name and maybe the part of the birth date or something to try to create a unique identifier. It's not so simple. Now, the other side of it, however, is you've got to be very careful, because a unique identifier also then ties together all of your records. There's one famous country, I won't mention their name, where the unique identifier failed because also the criminal record was attached to it. And so you have your health record attached to your criminal record. That's not a great fit. I think we would all agree. It's this kind of sensitivity. When we do a UPI, as it's known in the field, we have to be really very careful about how we choose it and how we safeguard it and who has access to it, etc. So just a caveat about that. Dr. Kevin, is the United States prepared for the next epidemic or pandemic? Is the systems that are being built today at Stanford or elsewhere, do you think are factoring in the learnings that we had from the COVID era?
I wish I could be more optimistic about this one. So we actually, I was part of a group that worked for our National Academy of Medicine to do an after-action report. And, so one of the things that came up is every single system that we built during the pandemic was an isolated data silo that didn't talk to any other system. We had Google and Verily building all these great access maps that you might have seen. We had all kinds of testing things set up. All of those were one-offs. And so, part of this goes back to the architecture has got to be there from the get-go. We now have, actually we had to pass a law to get the providers to work with the national system. And so every health information system now in the United States has to have an API so you can get your record. But we had to pass a law, and it took 5 years for the regulations to get implemented, to implement that law. The industry fought it like crazy. But I also want to bring up one other thing, which is, the other piece of the pandemic was how do we learn? So here was a brand new virus. No one had any idea what to do about how to treat it. And frankly, the UK recovery trials we talked a little bit about yesterday, the whole world leveraged those recovery trials to figure out how to treat patients. So the dexamethasone that everyone talked about yesterday, that was a recovery trial. The recovery trial did a convalescent plasma trial. I was part of one in the United States. They tracked, I think they did like 10,000 patients. We did 500 because it took us so long to get going and to sign up everybody. So the other part of the pandemic is how do we learn as quickly as possible what the right thing to do is. And I will say, and you should make a lot of fun of the United States because our leadership in at least the early days of the pandemic was not science-based in terms of thinking about this. But also our clinical community wasn't either. I mean, we were all trying our best for our patients, but even we did convalescent plasma outside the clinical trials because the doctors knew best. And so, we have to have the discipline to say it's really important for us to learn as quickly as possible from every single patient who goes through treatment in early days so that we could do a better job going forward. So that's another part of resilience, and we are learning a little bit about that and putting some resources into place for that. But to me, that was an equally important lesson. The vaccines were a miracle that we all got done in a year, but the rest of this really was in real-time clinical trials that gave us evidence about how to take care of the patients better.
Thank you, Kevin. And finally, Dr. Ida started this conversation about resilience, so we're going to ask her as the final one to reflect on your commission's experience in trying to teach the world about e-resilience, what kind of uptake you're getting from governments or any other agencies, how much uptake you get from Geneva, your own parent organization, the WHO. How much is this being taken to heart, and what lessons do you think the WHO and your commission can promulgate to, and I know you have in your hand some excellent booklets, and I'm hoping that she will give us more information about how we can get copies of these, because they're very, very interesting. So what's your reflection, Dr. Ida, and how prepared we're going to be?
Thank you, Dennis. Publications are all online. You can find them easily from our website. I will share with Access these 2 copies that I have now on digital transformation landscape. With regard to e-resilience and how successful we are as a commission to train, I want to highlight the work of SPECA, which is Special Program for Economies of Central Asia. We're running the working group on innovation and technology for sustainable development for 5 countries. And they have been actually asking us to develop the tool. There are 3 tools that we worked on, and this is one of them. And the commission, which is represented by different ministries and expert groups from STAN countries, right? Central Asian, Azerbaijan, Tajikistan, Uzbekistan, Kazakhstan, Kyrgyzstan. So these countries wanted to see the in prototype of e-resilience monitoring dashboard. They wanted to see the analytics. So this is an analytical framework. And they asked and tasked us to present the outcomes of these analytics to the next Innovation and Technology for Sustainable Development meeting, which is in October in Tashkent in Uzbekistan. So this is one. So we are mandated to work on this. And just because I'm very curious by myself, I expanded the e-resilience scoring for the rest of the Asia Pacific. And you can find analytics for the whole Asia Pacific. So we will be launching some working paper series by March, end of March. And then what was the other question? For next step? Okay, for the next step, since it's issue of connectivity and infrastructure, we have elicited and guiding, organizing the work of the Commission in three pathways. One is connectivity, where e-resilience part of that is informed decision-making around connectivity. Second one is digital technology. Third one is digital data. So I'm glad we highlighted today the cloud tech and all the digital tech products. And in this regard, maybe 2 more points. Interoperability you mentioned is so important now. So, but we need to do it meaningfully. So it doesn't create issues and bottlenecks, but create solutions. And the last point I would like to mention that apart from interoperability, we need to create more collaboration and cooperation. So thank you very much, Dennis.
Thank you, Dr. Ida. I would be remiss if I didn't call for questions. We're almost out of time, but we would be remiss not to take a few. So Dr. Vijay, you're first.
I think when we talk about resilience, and the natural tendency is to talk about infectious disease pandemics. But you could have a flood, an earthquake, or a volcano, and the first thing that'll go is power. What happens to digital systems when power goes? That's one question. And I don't want to waste time, so I'll follow on the second question. When is our Indian systems going to talk to each other? Soch, Nikshay, Ayushman Bharat, whatever. And when are we going to have everything available to us on an app, like Arogya Seti.
Like the rest of the world.
Right.
I like the rest of the world's industries, right?
And when are we starting to think about allowing people, lay people, to input their own data, including photo voice? It's such a simple thing to do.
No, in the interest of time, Dr. Vijay, let me answer it this way. We were 50 years behind before COVID, right? We're now 40 years behind. That's a 10-year catch-up. So we need to be a little bit patient. I'm hoping in my lifetime that we will catch up, and we will, not only the technologies you mentioned, but we mentioned AI a few times in this session. There's a huge potential for using AI in health. So I will take one more question. Please, ma'am.
It follows on from this previous question about times when resilience is actually called upon. In England, I know last year that hospital computer systems crashed because of the heat wave. Now, that was something nobody had anticipated. Heat wave, so this isn't even floods. So,
heat wave in the UK?
In the UK. And St. Thomas's Hospital, I'm pretty certain of my facts here. I'm sure I'm not, imagining this.
Yeah.
It actually did happen. So how are we preparing for these eventualities? And the second point comes from what Dr. Kevin was saying about how we are still working with 1960s models. Now, we give people an ID on computers based on home ownership. And I know in England, there's a problem with the homeless. And, if they don't have an ID, how do they even get on a system and get an ID? And I asked in Hyderabad, when I was evaluating the Arogyasri scheme, what were they doing about the construction workers building all those glass and steel edifices in Hyderabad and giving them an ID when they had no home address to give? And some of the people were scratching their heads and they hadn't contemplated that issue. And as we see more and more migrants as a result of the climate crisis, how are we going to cope with the fact that they may not be able to give you a utility bill and tell you that this is the home they own? So there are these problems we're not even imagining.
No, of course. And again, let me kind of short circuit the answer this way. I'll leave you because time is up. I know Uma is coming. So we... No. Let me end with a saying. Technology gives us back what technology had taken away. Think about it, okay? We are going to end up with many problems, many challenges. We're going to make some steps forward, and we're going to make some steps backward, right? The question is net movement, right? How much more improvement in health can we reach? Even though we have, look, I tell my students, we're at the very dawn of the computer era. It's in my lifetime that the first computer ever appeared. Just imagine if we were comparing that to the wheel, I don't know what, right? So we have a very short experience with computers. If you have a child today born in 2023, you can imagine in their lifetime what they're going to see. They'll look back at us like total dinosaurs when it comes to computers that overheat in the sun and freeze in the winter and Lord knows what, right? So we just have to live with that. That's the era we live in. But let's try to make the best use of computerization, digitization as we can to improve the health of every soul on the world's planet. I'll end you with that. Thank you so much. And thanks to our august panel for an enormously interesting discussion today. It's my pleasure to have moderated. Thank you all.
5 years young. That's how young you are and how agile you are with what you do in technology. And we are grateful that you moderated such a wonderful session. And like you said, with the generations to come will change. I know of children who actually know how to use a password on their parents' cell phone and they're probably a year and a half old, 18 months and all of that. So yes, we are seeing a revolution, and that revolution is only going to catch up and faster.
And it's only beginning.
Yeah,
Remember
it's
that,
only
especially
beginning.
young people in the audience.
Right. And those who see their children, don't get surprised. So I have the privilege. I am not going to sum these conversations up because I will have Dr. Reddy sum them up at the end of the day today. And I'm going to ask Supriya to please come up to help Dennis recognize, and Dr. Reddy to recognize Dennis for their wonderful contribution to this panel. Dr. Saab, you were not here when we had a very generous introduction of you while we were waiting. That's Farida, the color. Dr. Basant Garg. Dr. Basant Garg, we were able to introduce you in your absence. And thank you for being here despite all that you go through on an everyday with your challenges. Yes. Kiran, there's a lot of expectation from you and how Vijay put it for you. And then there's Kevin. Kevin traveled halfway across the world like you did. And I have Dr. Reddy to do that for you.
Oh, perfect. I'll wear this with pride.
Yes, thank you. Can we have the photo op together for everybody, please? Maulik, can I have you up here, please?